Okay, good afternoon, everyone, once again. So I think we'll start on with our presentation. I'll ask the presenter to unmute herself and present herself before she can get on with presenting, rather with delivering the presentation. Rudo, you can take over.
Good afternoon, everyone.
Good afternoon, Rudo.
Thank you. One more person can unmute and just greet me.
Good afternoon.
Okay, so my name is Rudo Dusenge Nalondwa, as introduced. Simon, will you help me with projection? Thank you.
All right, sure. Just a second.
All right, sure. Okay, so as we wait for him, I will be presenting today on the brain's vascular and ventricular system. So, I will begin with the vascular. So when you talk about vascular system, basically talking about brain supply, blood supply to the brain. That's the tongue twister. Yeah, so you're talking about blood supply to the brain. And of course, the brain is quite large, so you have arteries branching into and from somewhere into the brain. So I'll just wait for Simon to project me to page 24. Thank you.
Okay. Kindly confirm if you're able to see my screen. I think I'm sharing right now. Are you able to see my screen?
I can see it.
Okay. You can go ahead, Rudo. Rudo, are you there?
Page 24.
Oh, slide 24. Okay. Do you need me to go to slide 24? Hello, Rudo. Rudo.
Am I audible?
At some point, I can't hear you, so I'm not exactly sure if there's anything you said. Okay. Um.
Yes, Doc, we can get you.
Okay. Rudo, can you get me? I'm not sure if the presenter is in, or maybe she exited. Let me just try to confirm. Sorry. Okay. Welcome back, Rudo. Are you able to get me?
Can you hear me now?
Yes, I can. Okay. Can I go ahead and
thank
share
you. Can you hear me?
Yes, I can.
Yes, I am. Can you get me?
Yes, I can get you.
Oh.
Okay. You can go ahead. Rudo, we can get you.
I can't hear anything. Can anybody hear me? Can everyone hear me?
We can get you.
Yes, please. Page.
Hello, Rudo. Can you get us? Rudo,
Oh my God.
we can get you. We can get you clearly. I don't know if you're able to get us.
You can probably just call her and tell her that you are able to hear her. But
Yes, I'm able
hear
to get you. And thank you so much for taking us to page 24. Okay, so as I said earlier, basically, when you talk about the vascular system, you're talking about blood supply to the brain. And we can go ahead, ahead of those things, but then the slides in front are literally just words that I'm going to be explaining right now. So from our anterior, right from the heart, right? Like there's an artery that takes blood to the heart, and then we start from here where we have the vertebral artery, right? So this is where we're going to start from, because basically that's where blood supply to the brain starts from. So we have the two vertebral arteries. Here you can see. Oh, I wish I was the one sharing the screen. So I'm sure you can tell from
I think we lost the presenter. Let me just.
I'm back. Sorry, I'm so sorry that happened. I seem to be having problem with network. Hopefully, I have that sorted now, and I won't have that problem anymore. So basically, as I was saying, when you talk of blood supply to the brain, basically you're going to separate it into two. You have your posterior. Hello, can you get me?
Yes, we can get you. Please continue.
Ahead, and you would get me later on. So when you talk about blood supply to the brain, you're basically going to separate it into two. You have the anterior circulation, and you of course have the posterior circulation. This is very important. Yes, we will later on find out when we look at the clinical correlates why it's very important that we understand what arteries supply blood to which part of the brain and which artery does what, basically. So this is very important and is basically the basis of understanding the clinical correlates, which we're going to look at later on. So the brain has a high oxygen and nutrient demand. It's basically the highest oxygen and nutrient demanding organ in the body. And as I said earlier on, you have the anterior circulation and the posterior circulation. And of course, we start with the posterior circulation because we're basically, the blood comes from the heart, from down there. So it's, it's going up. It's a down-up movement. All right. So we'll start from the posterior circulation, going up to the anterior circulation. Okay. So when you talk about
back to the previous slides.
No. We'll just look at. I would rather people hear me explain what we're looking at. Yeah. So the posterior circulation is, we are going to divide it, right? We're going to divide it into, it's basically from here where you have the vertebral artery, which you can all see in the diagram, right? You're all able to see Manuel's screen. I need somebody who's not in manual to confirm they can see the screen.
Yes, we can.
Okay, good. So your posterior circulation basically starts from the vertebral artery all the way to the posterior cerebral artery. Okay, so now let's get into that and just see how the arteries are. So you have the vertebral artery, which is the blood mainstream, really. This is how the blood enters the brain. Yeah. So from the vertebral artery, it gives off. Can you enlarge it? I'm trying to enlarge it, and I realize this isn't my screen. Can you enlarge it just a bit, like on the vertebral part, the down part?
Okay. Are you able to see it?
Yes, I can. Thank you so much. So your vertebral arteries are, those large things, the bigger. Oh God, I was not showing my screen. Yeah, exactly. Thank you so much, Emmanuel. So that's your vertebral artery, which branches off into the posterior inferior cerebellar artery. Okay. So the posterior cerebral arteries, they basically bifurcate from the vertebral arteries. Are we together?
Yes, we are together.
Thank you. And this supply the brain stem, the cerebellum, the posterior cerebral cortex, and the medial temporal lobe. Okay? So we keep moving. As the vertebral artery keeps moving, we then bifurcate, like from branches off, really, like just branches off. So the posterior inferior cerebellar artery, okay, branches off from the vertebral artery. Okay, and then we keep going on, we keep going forward, and then we have the interior inferior cerebellar artery. So that's the first branching off from, wait, no, give me a minute. I took it too far. The vertebral artery goes like it becomes one, as you can see, like the two things become one. And this one branch is called the basilar. All right, the basilar artery. This large thing, this large stem, it looks like a flower stem. I'm sure you can see it, this middle thing, all right? That's the basilar artery. Now, depending on the shape of your mouth and your basis of English, it's either basilar or basilar. But yeah, let's go with basilar for today. So from your basilar artery, you have these two at the base, right at the base of the basilar artery, right? You have the anterior inferior cerebellar artery. You can see it, right?
Yes, we can.
Okay. So the anterior we can move past it really, and we continue with the basilar artery, and you have these arteries called the pontine arteries. Okay?
Yes. Yes.
Now, remember I said the vertebral and basilar arteries supply brainstem, cerebellum, posterior cerebral cortex, and the medial temporal lobe. So now I hope you attended last week's class. If you didn't, we have a YouTube channel where the videos are stored. So you can go back and watch it, because Emmanuel really explained on these parts that I've just mentioned. Okay. So, and then moving on from the pontine arteries, we have right at the base, it's like a flower really. I'm sure you can tell, like there is this circle in the middle, and then you have what looks like petals. I'm sure if you drew flowers in grade 5, when we're looking at flowering plants, you can tell that this looks like a flower. You have petals here at the end with, little nice flower in the middle. So the petals here at the end, we'll start with the first part of the petals, which we are calling the superior cerebellar artery. Can you all see it? I'm sure you can see it. Like thank you very much. The very first part, the very first branching off really is called the superior cerebellar artery. And then you have the second branching, which you can all see, right? And this marks the end of the posterior circulation. So now allow me to mention that when I started studying this, I thought the circle of Willis is like everything really, like the whole, middle part of the brain's circulatory system. But the circle of Willis starts here because the circle of Willis is basically when the posterior circulation and anterior circulation, the place where they meet, that's the point that you finish on the shape of your mouth. So so this starts our anterior circulation. And to begin our anterior circulation, we will first talk about the internal carotid arteries. I hope you can all see it.
Yes, we can.
All right, so this is responsible for supplying a large portion, a very large portion of the anterior and middle parts of the brain. Okay, so the way it's divided really, and it also has its own division, and we have, depending on which one you're comfortable with, you can either use the new classification or you can use the old classification. I prefer the old classification, it makes more sense. The new classification basically divides the internal carotid artery into 4 parts, which is the cervical part in the neck, the pectoris in the base of the skull, the cavernous within the cavernous sinus, and the intracarnal above the cavernous sinus. But we won't get into all that today. And then, of course, you have the old classification, which is in segments, which I prefer because you're memorizing, I think. So, yeah. Emmanuel, you can take us to page 8, just so that we can see how it's divided, how the internal carotid is divided. Okay, thank you. So as I said, this one is the new classification. This one is divided in the new classification series. Yeah, so you have the cervical part, the percutaneous part, the cavernous part, and the cerebrous part. Okay, we can go back to page 24. Yeah. So the internal carotid artery also supplies. It's responsible for the stomasensory and motor correlates of the lower limbs. Now, this will later be important as we look at the clinical correlates of this system. Okay, so I'm sure you can tell where the internal carotid is. Can we also, thank you so much, yes. So I'll move on to the anterior.
Hello, Rudo. Rudo, are you still there? Okay. I think you should be experiencing the same network challenges. We just give I think a few seconds or a few minutes as well.
Okay, sorry about that. I received a call. Yeah, so I'm moving on to the
Yes, Rudo, you can continue. Oh, okay. Pardon us for that. I think the presenter is still having the challenges with her internet connection, so I think you should be able to join us back in a short while again.
Can you hear me?
Yes, we can get you. Please continue.
All right. Okay. So I'm moving on to the posterior communicating artery, which hello?
Yes, we can get you. Please
Okay.
continue.
So the posterior communicating artery is the long, can we see it?
Just a second.
Is the long slender vessel originating from the posterior cerebral artery. So that one, yes, thank you. So it's much longer. It's way longer than the anterior communicating artery, which we're getting to. We will get to it. Yeah. So the posterior communicating artery basically completes the circle of Willis. Like I'm sure you can tell. Like it makes the base part of the flower. That part, yes. So yes. And additionally, it sort of it gives tributaries to the optic tract, okay, and the thalamus. Yes. And then moving on, I will look at the anterior.
Rudo, are you still there? Hello, Rudo.
Hi, can you hear me?
Yes,
now?
we can get you.
Am I audible?
Yes, you're audible.
Okay. So now I will look at the anterior. I was talking about the anterior communicating artery before I was cut off. I don't know what happened. Which is at the top part. I'm sure you can all see it, right? The anterior communicating artery. It's sort of, it's like a bridge it's like a bridge with the anterior cerebral artery. Like, you have two anterior cerebral arteries, and then there's that bridge in the middle there. That's what we're calling the anterior communicating artery. Okay, so I've basically looked at, or you can take it back to normal now, thank you. I've looked at, or I've just given you, like every artery in the brain, and now I'm going to tell you what each, what each artery supplies blood to what. Okay, so yeah, we talk about the anterior cerebral artery, which is right at the top. I'm sure you saw it. So this artery supplies the medial portions of the frontal and parietal lobes. Okay, so the frontal, the front part, I really wish I had my camera on. Yeah, the front part and the medial portions of the frontal and parietal lobes, right? And it also supplies blood to the corpus callosum. All right. And then the middle cerebral artery supplies large portions. It supplies blood, obviously, to large portions of the frontal, parietal, and temporal lobe surfaces. So it's like on the top part of the brain. It supplies blood to those areas of the brain. And then branching off from this, which we also in the diagram, is the anterior and middle cerebral arteries. Okay, so this supply the basal ganglia and the anterior limb of the internal capsule. I really suggest you watch last week's, if you don't understand some of the terms I'm using, I really suggest you watch last week's teaching, to get some of these parts that I'm mentioning, which are all present on YouTube, as I mentioned earlier. Okay, so like I said, they supply blood to the basal ganglia, the anterior limb, and the internal capsule. And then now back to the posterior circulation. As I mentioned, the vertebral and basilar arteries supply to the brainstem, the cerebellum, the posterior cerebral cortex, and the medial temporal lobe. And then I also mentioned the posterior cerebral arteries, which, branch off from the basilar arteries. This supplies blood to the medial temporal and optical lobes. Okay? Yeah, and of course, the anterior and posterior circulation, the communication of this is what we call the circle wheels. Now, getting to the interesting part of this entire topic is the clinical correlates of the vascular system. We can go to page 25, though I won't be looking at it much. So the reason why the PowerPoints are so ready is because even if you do get the PowerPoints minus the video, I feel like you should be able to understand everything I've just mentioned concerning the vascular system. So yeah. So going to the clinical correlates of the vascular system, we are going to look at stroke. Now, if you grew up in a house like mine, where you had someone come help you with the cleaning, I was always intrigued by stories of her relatives abalwala stroke. Somehow they all had stroke. So reading this PowerPoint was very interesting for me, or reading this part of the whole topic was very interesting for me because I finally understood what she was talking about. So stroke is basically like little to no blood supply to certain parts of the brain. And depending on which artery is blocked or which artery is not supplying blood, you have different symptoms, different signs in a patient. Okay, so stroke can either be ischemic or it can be hemorrhagic, right?
Yes.
So usually ischemic stroke is either from thrombosis or embolism, which I believe you have all looked at in basic pathology. Like, hallelujah. So yeah. So we're going to look at the ischemic. Ischemic stroke is like no.
Okay. I think the presenter is having the same challenge with network. I think we just give her a couple of seconds to come back to rejoin her. Okay, she's back.
Okay, sorry, I'm using Zamtel. So I'm sort of having trouble with network every once in a while.
Okay.
Apologies for that. So, thank you. So ischemic stroke is, you have an embolism, you have artery-to-artery embolism, or you have thrombosis in one of the arteries. What's that? Okay. So it produces, sudden neurological defects which persist more than an hour. So now we have certain people, thinking they have stroke because they have symptoms of stroke. Just a second, what? Right. So you have certain people coming, to the hospital because they have signs of stroke, and somehow still manage to walk to the hospital. But we have a word for that, which is transient ischemic attack. So this is like where you have symptoms, you have basic symptoms of stroke, but then they last less than an hour. Now, this shouldn't be ruled off completely. They could lead to stroke, but
Hello, Rudo. I don't know if you're still talking, but I think we cannot get you. I'm not sure if Ndelman is not getting you. Okay, I think she'll be rejoining in a second or so. So kindly wait for her to do so. Sorry, once again, I'm trying to get in touch with the presenter. I think she's trying to find an alternative internet provider. So kindly give her a few minutes or so. I think she should be able to give us feedback in a short while. In the meantime, how are we finding the presentation so far? And if at all there are any questions, you can kindly send them in the, yes, you can send them in the chat box, and then I think the presenter will be able to tackle them once we are done with the presentation. In the meantime, you can kindly share any comments that you have for your, or rather for the presentation, if there are any.
Okay.
Welcome back.
We bless God for Zamtio. Thank you. Okay, so I'll just go straight to what I have to do because I still have another system to do. So, like I said, depending on which artery has embolism or thrombosis, you have different symptoms or signs in different patients. So if you have and I won't mention each and every one, but each and every artery because it's a whole lot. But I would definitely mention the key arteries, the most common arteries that, yeah. So the anterior cerebral artery, okay, I kind of found conflicting information on this particular artery being blocked. Some said it's common and others said it's not common. But when I did further research, I found out that it's common in certain areas and it's not common in certain areas. Like it's common in certain parts of the world and it's definitely not common in other parts of the world. For example, if you talk about the anterior cerebral artery, being blocked or anything like that in places, it's kind of, it's a trick thing, you know. But anyway, when you have your anterior cerebral artery blocked, this is where you sort of lose function in your lower limbs, you know, like you don't walk, kind of stuck to a wheelchair. Yes. You also have urinary incontinence. You have apathy. You have confusion and poor judgment. This is under ischemic stroke. So, yeah, these are but I feel the main symptom that you're going to see, the main sign that you're going to see in patients that have their anterior cerebral artery blocked is loss of function in their lower limbs. Okay, and then you also have middle cerebral artery. So when you have when your middle cerebral artery is blocked, you have molecular loss of vision, and this is only if the internal carotid is affected as well. Okay? Yes, so you have that, you have sensory neglect. Hello, can you hear me?
Yes, we can get you.
And then you also have contralateral hemiphasis. If you have the middle cerebral artery blocked. And then if you have your posterior cerebral artery blocked, you have memory loss, unilateral third canyon nerve palsy, and cortical blindness. Unilateral cortical blindness, memory loss, and unilateral third canyon nerve palsy. And then if you have your vetrovascular, like this is basically the posterior circulation, right? So this is just like one thing. So if you have your vetrovascular system blocked, then you have symptoms like vertigo, impaired consciousness, coma, and usually, mostly, death. Because your blood isn't, your brain isn't getting any blood really. Like imagine the ventral part, that basis part, like is cut short of blood. It means the rest, all the other arteries won't receive blood, and you get to come and die. Yeah. So those are some of the symptoms that you're going to see depending on which artery is blocked. So this umbrella thing of navalwala stroke, like as medical people, you should know, okay, it's stroke, yes, which artery is blocked, which artery is not functioning, and yes. Remember, I also said that stroke can either be ischemic or hemorrhagic, right?
Yes, we can get you.
Do we remember that, or am I alone?
No, I think we remember.
So you have something called intracerebral hemorrhage. So intracerebral hemorrhage is basically bleeding from blood vessels within the can you hear me?
Yes, we can get you.
So like I was saying, the diagnosis and treatment of the intercerebral hemorrhage is bleeding in the blood vessels within the brain parenchyma, right? So this is usually caused by hypertension. So you have, when your patients are, hypertensive, then you have this intracerebral hemorrhage as, something that can happen to them. So treatment includes like BP control and supportive measures, of course. And then signs of someone that has intracerebral hemorrhage, usually headache, nausea, and impairment of consciousness. Yeah. And then we also have subarachnoid hemorrhage. Okay? We can talk about this when we look at the ventricular system, which we'll get into just now. Okay, so when you talk about ventricular system, you're basically, the first thing that should come to your mind is cerebrospinal fluid. Because when you look at the ventricular system, you are basically, so you can take us to page 37, just so we can have a picture of what we're looking at. So when you talk about ventricular system, the first thing that must come to your mind is cerebrospinal fluid, because yes, when you talk of the ventricular system, you are looking at spaces really in the brain, that are that are responsible for the production of cerebrospinal fluid with the help of the organ that's found in them called the choroid plexus. Okay, so inside the brain, there are basically 4 spaces, right? There are 4 spaces which we can see in the diagram there. We have the lateral ventricle. We have 2 lateral ventricles. Those things that look like ram horns, Yeah, you can see them, right? Yeah. So you have the lateral ventricles, 2 lateral ventricles. You have the 3rd ventricle, the one which is there in the middle, and of course the 4th ventricle. So the lateral ventricles produce the most cerebrospinal fluid. Like I said, each ventricle houses an organ called choroid plexus, right? So the choroid plexus is the one that produces cerebrospinal fluid. And when we look at the lateral ventricle, we can further subdivide it into 4 parts. We can further subdivide it into 4 parts, and each part has a choroid plexus. So you can see that, it has 4 spaces, and each space has this organ. So obviously it's going to produce the most cerebrospinal fluid. So anyway, to break down the lateral, by the way, when I break down the left ventricle, I'm breaking down the right ventricle as well. It's basically the same structure, just 2 of them, Yeah. So there's the central part. The central part is located in the parietal lobe, right? It's the C-shaped cavity. It's like the C-shaped part of the lateral ventricle, and it's located mostly in the parietal lobe. And it does contain a it does contain a choroid plexus. And then you have the frontal horn. Frontal, so it's, you know, it's that part which is in the front there. You can see it, right? Yeah. So that part which is there in the front, that's the frontal horn. That's the frontal horn of the lateral ventricle. And yes, it does contain. It also does have and then of course they are separated medially from each other by the sternum.
Hello, Rudo.
Can you hear me?
Yes, now we can.
Where did you stop hearing?
I think you're saying something about what connects the two lateral ventricles.
Okay, yeah. So it's separated medially, okay, like in the middle there, from each by the sternum pellucidum. Okay.
Yes, you can see it.
Mm-hmm. So now we are looking at the optical horn. Are we together?
Yes, we are. We're following.
So we've done sorry, let me just make sure because my network is acting funny. So we've done the central part of the lateral ventricle, right? We've done the frontal horn of the lateral ventricle. We've done the temporal horn of the lateral ventricle, right? And now we're on the optical horn. We were together through all this. So the optical horn extends, it's like the down part, the lower part of the lateral ventricle, you know, that lower part. It's a finger-like projection. I'm sure you can tell. It's the right at the ends of right at the ends of these ram horns, I so call them. I think they look like ram horns. It's better to remember them like that. Yeah. So its flow contains a color as this, you know, and a collateral trigon. Okay? So this part of the lateral ventricle is basically encircled with white matter. All right. We move on to the third ventricle. So you can tell, from everything I've explained, you can see that the lateral ventricle, you know, it has a lot of these choroid plexus. Yeah. So we move on to the third ventricle. The third ventricle houses just one. It houses just one choroid plexus. Okay, so it looks like a narrow slit. I'm sure you can tell from the. I want you to look at the anterior view, not the lateral view, but the anterior view. It looks like a slit, if you can tell. Like it doesn't look that much, you know, from the anterior. But when you look at it from the third ventricle, you see that it has a little bit of space. So corpus
Yes, Rudo, you can continue.
limited and the anterior. Wait, you couldn't hear me?
For a while, but then we can now get you.
Oh, okay, sorry. All right. So where did you stop and start hearing me?
I think the last thing I got before you broke was you talking about the third ventricle being a slit in the anterior view.
Okay. All right. So the roof of the cavity is the roof of the third ventricle is formed anteriorly by the fornix and posteriorly by the splenum of the corpus callosum. Did you get that part?
Yes, we did.
Okay. But not as much as the lateral ventricle. And this is because as you could tell, the lateral ventricle has more of the
Sorry, we've stopped getting you.
Now?
Yes, we can.
All right. So I was talking about the fourth ventricle. Now I'm not talking about the fourth ventricle. I said before I cut off, I said that the third ventricle, it does produce cerebrospinal fluid. It does produce cerebrospinal fluid as well, but just not as much as the lateral ventricle does. So looking at the fourth ventricle, it's the most imperial of the four ventricles, you know. It's yeah, it's sometimes just don't know why certain things, but anyway, yeah. So it's basically anterior to the cerebellum and superior to the medulla oblongata. So yeah, that's where it is located. That's where the fourth ventricle is located. It produces very little cerebrospinal fluid, like very, very, very little cerebrospinal fluid. So now, where does this does the cerebrospinal fluid stay in the brain and just sit in those spaces? No. The
We've stopped getting you again.
Yes, as I was saying, before you stop getting me, sorry, the cerebrospinal fluid is definitely produced in the ventricles, in the ventricular system of the brain, but it surrounds the brain, it sort of cushions the brain, you know. So in terms of things like you have a brain injury, you know, it cushions, it acts as an absorbent, right? The cerebrospinal fluid acts as an absorbent in such instances. So it does move and fills in the space between the arachnoid matter and the pia matter. I suggest you read. Okay, I think there's a diagram that. Yes, you can go to page 40 for me. Thank you. So I'll explain this diagram later on, but then I just want you to see, you know, the space where the cerebrospinal fluid, like, you know, gets into. Okay.
I take you back to the previous slide. Rudo, we can't get you anymore.
Oh, you can leave that. You can leave that page, and we can go back to yeah. Thank you. So I will begin to look at the flow of cerebrospinal fluid. What's the time? Yeah. So flow of cerebrospinal fluid. So when
We've stopped getting you again. Hello, Rudo. We can't get you again. I don't know if you're still in the meeting.
wow. So we're looking at production. We've looked at the production of cerebrospinal fluid. We're now looking at the movement of cerebrospinal fluid. So cerebrospinal fluid moves. When it's produced in the lateral ventricle, it doesn't stay there. It moves to the third ventricle, and then it mixes with the cerebrospinal fluid that's been produced in the third ventricle, and that moves as well. And yeah, in the fourth ventricle.
I think we've lost you again.
Okay, so can you hear me?
Yes, we can.
Yeah. So I said very little cerebrospinal fluid is produced in the fourth ventricle. So it mixes with like it just keeps going, and then it exits the fourth ventricle to either enter the central canal of the spinal cord to enter systems. Okay, so
We've lost you once.
Hence joining system. You were saying something?
Yes. Anyway, it's okay. You're back now. Is it possible for you to find an alternative internet connection real quick, maybe for like 2 minutes or so?
Yes. Yes, it's very possible. Just give me 3 minutes.
Okay. Just be quick, please. Okay. So as we wait for the presenter to find an alternative internet connection, you can kindly submit any questions that you have so far. I'm sure there are people in here who will be able to answer those questions. We can bring them forth. Yeah, we can bring them up as discussion questions that we can discuss as we are waiting for the presenter to come in. I've noticed we have a couple of seniors in here. Maybe I'll just give them an opportunity to share any comments that they have, or any contributions that they have so far concerning their presentations. I think the first one would be sorry, let me just. Yes, so we can start with Dr. Sichimba. Doc, you can give any comments that you have so far as we are waiting for the presenter to come back in, if you have any.
Well, I think I just typed something. What if the questions are specifically for the presenter? Because the whole purpose of the questions is it's and the comments, by the way, it's for both the presenter and us, the panel, for all of us to learn. So if I ask a question or I make a comment and the presenter is not there to listen, I don't think it will. Yeah, I don't think it will benefit her. Yeah. So I think I'll ask the questions and make a comment once she's back, or probably at the end of her presentation. Thank you.
Sure, no problem at all. So if there's anything else other than what is related to the presentation that anyone would like to bring up as we wait for the presenter to come in, we can bring them forth. So anyone from the audience among the participants can just bring them forth. I've seen there already. I've seen we already have a couple of questions that are in the chat box, and we can continue bringing them in, and then we'll be able to. I think the presenter will be able to tackle them as yeah, she'll be giving us feedback at the end of the presentation. Rudo, are you back?
Yes, I am.
Gotcha.
Hopefully this works.
Please carry on.
Okay, so I was talking about cerebrospinal fluid. I was talking about cerebrospinal fluid flow, the flow of cerebrospinal fluid from the lateral to the third, from the lateral ventricle to the third ventricle to fourth ventricle, and it either enter the spinal canal of the spinal cord or the foramina of Mangandi, right, to enter the cisterns. So allow me to explain what a cistern is. The cisterns are subarachnoid space that between it and the underlying pia mater, right? So these are just points between that exist in the underlying pia mater. So we can just go back to the diagram on page 40. Are we there?
Yes, ma'am.
I cannot look at my screen. Right, so yeah, from there you can tell and you can see the circulation as it's moving, to just cover that space. Can we all see it? And then of course it leaves and joins the systemic circulation. Breaking anymore. Can you hear me, Manuel?
Yes, we can get you, though your line was breaking at some point, but we can get you now.
Okay. Okay. So please, if you just hear like any prolonged spaces, you can just inform me as soon as possible so I can quickly correct it.
Okay.
So I will now look at the significance of this system.
Okay.
I'm still breaking.
Yes, but I think you're back now. You can continue.
So I'll look at the clinical significance of this system. Which is usually categorized by a big head.
I think your line has broken again. Can't get you.
Okay, so can you hear me now?
Yes, we can.
All right. So I was saying when we look at clinical correlates, we look at hydrocephalus, right? Hydrocephalus.
Yes.
Which is highly
Rudo, we can't get you.
okay. So I switched my network, and it's unfortunately it's still the same thing. So, oh.
Okay, sure. Anyway, just continue with whatever can work.
Presentation. All right. Let me just keep moving, and then I think it will be like connecting as we go. So as I was saying, this is like an overproduction, right? This could be because of overproduction of CSF. All right, and then not much of it is being removed from the carnovault. So there's an obstruction in the CSF flow, which means that, like fluid is accumulating. So this causes, like you have a lot of water in that space. Atrophy of the brain. Okay, because it's been suppressed by this fluid that's not moving. We can also call CSF accumulation as communicating hydro. So this is usually, it's usually caught when an individual is still young, like when they're still in their infant stage. That's when it's
Rudo, are you there? Rudo, we can get you.
Yeah, I heard that in the
Okay.
video trying to correct it. Okay, so, and then of course, other pathological presentations would be dependent on the nuclei and nerves that are compressed by, the excess cerebrospinal fluid. So let me just go through the whole disease again, because I kept being interrupted with Rudo. I can't hear you, so I can imagine people have heard little to nothing of what I said. I hope you can get me. So I was talking about hydrocephalus, which is basically an overproduction of cerebrospinal fluid in the brain, right? So this is usually but can
I think it looks like the internet connection you're using now is presenting more difficulties than the previous one. Maybe you can just reconnect to the first one you were using it when you just started the presentation.
Okay.
Yes. So I've seen the couple of questions that that have already been submitted in the comment section, so you can continue submitting them, and I'm sure we'll be able to tackle them once the presentation is done. So in the meantime, we'll just wait for the presenter to reconnect. I hope this time around it works better. So once again, kindly pardon us. Kindly pardon us.
Okay, I'm back. Can you hear me?
Yes, we can.
Hello?
Yes, we can. We can get you. Please continue.
All right. So as I was saying, hydrocephalus is a ventricular enlargement, all right, which is like excess CSF. And the manifestations of it include an enlarged head and brain atrophy. So increased carnal pressure causes irritability and bulging fontanelles in infants. And it's the most common cause of abnormally large heads in neonates. So these are like children, infants. So it can result from either an obstruction of CSF flow or impaired reabsorption. The treatment usually is with ventricular shunt procedure. Like usually that's the treatment of hydrocephalus.
Yes, you can continue.
Okay, so you can just, you were saying something?
No, I was saying you can continue. Networks are you had stopped.
All right. Symptoms and signs are usually intracranial pressure is increased, symptoms of which include headache, high-pitched cry, vomiting, or decreased vision. Okay. So, like, usually if you notice, a child's head is beginning to bulge, I think it's safe, especially like really small children, it's safe to take them to the hospital as soon as possible. Okay, due to time, I think I'll end here. And due to bad network, I think it's safe to end here.
Okay. Thank you very much, Rudo, for the presentation. I'd like to believe the anyway the presentation was.
Hello.
Yes. We can get you. Yes. Yes. Thank you very much once again to the presenter for the presentation. I can say it was detailed, and I think just the disruption of the internet connection has what's been the biggest impediment. But all in all, the presentation was sufficiently detailed, and I'm sure there are so many things that we've learned. So I think we'll just dive into our contribution and Q&A session. So maybe we can start with comments first. I think we actually started with that. Maybe we can just have a few individuals point out some rather given some contributions for the presentation before we can dive into the questions that have been submitted as well as those that have not been submitted yet. So since we already started with Dr. Darwin Sichimba, maybe you can just continue with you can just pick up from where you ended, and then we can go on to the others.
Right. Thank you so much. So you're saying this is time for contributions or comments and not questions, right?
No, not questions, please.
Okay. Right. Firstly, this is a good program. I think this should be my second, if not first, that I'm attending. And congratulations, Rudo, on successively presenting despite the challenges that you are facing with network. So the main comment that I have is on seriousness when you're presenting. When you're presenting, you should also know that you are preparing for future presentations on big forums. And in such a case, you need to put up some seriousness. I don't know, maybe that's how it is always. When these presentations are being done here, pardon me if I've gone outside, but I think those more of like it wasn't, you're not taking it so formal. Okay, so next time try to make sure that you're more formal, less of jokes, less of laughing, yeah, and yeah, especially I don't know if this was being recorded as well, I'm not sure, but especially if it was being recorded, then you expect that a lot of other people are going to reach out to that video and so on. So for purposes of preparing for future present. By the way, this is not only going to Rudo, it's going to everyone else that probably has never presented before, especially. So let's make sure that these are as formal as possible, we're as formal as possible. And then when it comes to the presentation itself, I think you prepared a number of slides which you didn't use. Okay, from what I noticed, the whole purpose of preparing a PowerPoint presentation is to use all the slides that are there. If you want to use diagrams, then only put diagrams on the slides that you've prepared. Okay, less of words, especially something that has to do with anatomy, like in this case, you use more of diagrams and less of sentences or other words. So like in the case, like in your case, you used slides where there were diagrams or other way. I think on the brain vascular system used only one diagram, if I'm not mistaken, where there was the circle of Willis, and you probably explained everything from there. Now, that for me, that made it a bit confusing, because I then started asking myself whether it was the whole brain vascular system or it was just the cerebrovascular system. So if you explained the circle of Willis and everything to do with the circle of Willis, then it limited it to the cerebrovascular system. Yeah. Then I think on definition of hydrocephalus, I think I'll ask. I think when it comes to questions, I think I'll ask you to define it again, and I'll ask further questions. Otherwise, those are the comments that I have. Thank you.
Thank you so much, Doc. I'd like to believe the presenter has taken note of the comments, and I believe everyone else who's in here has taken a note of the comments, because I believe these are not just comments that apply specifically to the presenter, but I think these are lessons that we can pick up for future presentations that we may be offered to deliver. So next one, I think I can give the opportunity to Dr. Danny Kambole. If you have any comments, kindly bring them forth.
Hi everyone. I think much of what I wanted to say has been said by Dr. Schimba here. I think it's important. I used to be a victim of this being too casual. I remember when I first did a presentation in source method year, yeah, it was a blunder. I was joking too much and all. But I think it's important to realize when you give your presentation to an audience, whether they are your friends or what, you need to be serious for the sake of the future presentation and your personal training. Because instead of people focusing on the data that you're presenting, we get carried away with jokes and all, and miss the very important information. So on the part of comments, I think Darwin has done justice. Thank you.
Thank you very much. I think I can also see another senior of ours, Dr. Kwesi Afrie. Please, if you have any comments, kindly bring them forth.
Hello.
Hello.
Am I audible? Okay. Most of what I wanted to say has already been mentioned, but my comment is going.
Sorry, we can't get you.
I'm saying, hello, can you hear me now? Okay. So towards the beginning of the presentation, when the presenter started taking us through the cerebrovascular system, for me, it seemed like she started along the way and not from the beginning. I think it would have been prudent for the presenter to have started from the source, perhaps from the left ventricle, to give us a proper sense of the arterial geography of where we're starting from and where we're headed. It seemed like we just started from the middle, then we headed towards the brain. We could have started from here, just for future reference. Perhaps we could start from the left ventricle, talk about the arch for a bit, the three branches from the arch of the aorta, and from there up to the brain. I think that would have been better than where we started from.
Thank you.
Thank you. That's it.
Thank you very much, Doc. I think that's something we can all learn from. I think we are definitely not all masters. Maybe we've presented a couple of times, but I think there are still a lot of lessons that we can pick from this. Thank you so much. I'm not exactly sure if there are any other seniors who are in attendance. If there are any.
And I think another thing which we need to work on is that if we give a junior student, especially very junior student, to make a presentation, let's not leave it unguided. Let's not leave it up to them to just come up with things to present and come and present here. I think I don't know if you did this, but I would assume that you didn't. It's important that maybe before the day before the presentation, you get to meet them and they present to you so that you make corrections before they present to the bigger audience. I think you used to do this with Mr. Ngara earlier on. I don't know if that was done, because if that was done, I think even this question has brought up, I'm sure it would have been corrected, so that as they come here, because it's important that they present they actually also learn. So that as they come here, they would have a lot of things that would have been polished up, and yeah, we will remain with very few collections. Yeah. Thank you.
Sure. Thank you very much. That's very much taken note of. And I think maybe that's also something that falls back on us as the seniors who were supposed to guide the presenter through this. But thank you very much for the comments. So I think I'll leave it open for any other individuals who would like to make any comments before we dive into the questions that have been submitted so far. So any other comments? Okay, so so if there are no comments, I think we'll get straight to the questions that have been sent. So I think the first question was already answered by one of the participants. I think the first question was on the aspect of I think the presenter mentioned something about the sternum instead of the septum pellucidum. So I think that was already rectified. So there's a question from Morpheus Scott which says posteriorly the roof of the third ventricle is formed by what again? I think there was a time when the presenter was talking about the third ventricle. So can you just clarify what forms the roof of the third ventricle? Rudo, that's for you. Rudo, are you here? Okay, so maybe we can just throw it to the audience. If there's anyone who has the answer to this question, kindly assist us, rather than first wait for the presenter. So the question again is what is the posterior roof of the third ventricle? Okay, I think the people to provide the answers are still working around it. But if there are any questions, kindly bring them forward so that we can tackle them. It could be about the presentation itself, it could be about any other thing that concerns or is related to the club. Okay, so there's a response from the presenter. So she's saying anteriorly, the roof of the third ventricle is formed by the fornix, and posteriorly formed by the splenium of the corpus callosum. I hope that's clear. So that's the answer to the question we have there. And then I don't know if there are any other questions before we can dive into the last segment of our presentation, and then we close the session. Okay, so if there are none, I think I'll hand over to the president if she has any comments before we can go on and. Ebenisha,
thank you so much.
All right, sure, you can go ahead.
Sorry. Thank you so much for that, Emmanuel. Rudo, thank you for the presentation. I think it was fairly done, coming from a preclinical standpoint. Thank you so much for the effort and for putting in your work towards the presentation. It was a good start. And I'd like to thank everyone who also attended the meeting. Seeing as we are most grateful for the feedback that we have received. We'll surely work on it, and we hope that we'll all attend the next meeting in approximately a fortnight. Emmanuel, you can go ahead.
Thank you very much. So just to add on to what the president has said, so our team, rather we're actually running a neuroanatomy series. So we have a couple of presentations that we are having. This was the second segment of the neuroanatomy series. So we anticipate to have 3 or 4 more other lectures, depending on how, rather presentations, depending on how our calendar allows us to have the activities. But all in all, I think that's basically everything. The rest of the information that needs to be communicated should be communicated during the course of this week. I think we have a couple of announcements that the club would like to the club would like to deliver. But I think during the course of the week we'll be able to find out what those are. Otherwise, I think this marks the end of our meeting today. Thanks to everyone who made it, and I hope to see everyone here the next time we'll be having our presentation. A good evening to all.